Dr. Anand needs no introduction, so he'll be talking on intravitreal steroids and its current role in the anti-VEGF era.
Thank you. It's a pleasure to be here. So, steroids, as you know, was like a panacea at the turn of the millennium, and it was like steroids for everything. But then, in the post 2005-6, when the anti-VEGF era came in, uh, kind of displaced steroids and pushed it to the back burner. So let's look at the role of steroids. So largely, in our practice, it has a role in DME, diabetic macular edema, retinal vascular occlusions, and uveitis. And we'll look at a few other miscellaneous roles too. So intravitreal steroid therapy, largely in our part of the world, is triamcinolone, acetonide, Kenalog, Tricot, or Oracort, can be used usually in the doses 4 milligrams in 0.01 ml, or half dose, which is 2 milligrams 0.05 ml, which is what we are doing mostly in Arvind. Then there is the sustained release device, this dexamethasone implant, also dex 0.7 milligrams. Okay, it's a sustained release biodegradable implant. What is the mechanism of action? It has anti-inflammatory effects by modulation of the production of cytokines and growth factors, including VEGF, and stabilizes the blood-retinal barrier with reduction of vascular permeability. So in DME, DRSA net protocol, I looked at the role of steroids vis-a-vis anti-VEGF. So you had two anti-VEGF, ranibizumab and laser combination arms, where one was deferred and the other was prompt, and then you had the laser only arm and IVTA prompt laser arm. So the 2, 3, and 5 years results showed clearly that the ranibizumab arms were better than laser only or IVTA prompt laser arms, and of the two, the deferred laser arm was better. And the IVTA arms are the only ones, as you can see, which were associated with elevated intraocular pressure, which we know is a problem with steroids. And more than half the patients ended up having cataracts and needed cataract surgery. But is there a role? So when you look at the subset analysis, you find that there still can be a role in especially diffuse diabetic macular edema. As you see that purple graph, this is where there was the maximal benefit of the loan, and perhaps this is one place where you have a significant role. Also in patients who are pseudo-phakic, so that issue of cataract is already taken out. By combining intravitreal steroids with anti-VEGF, the DRCR protocol, you try to look at it, but remember this was for persistent DME, where 3 anti-VEGF injections had been given in the 20 weeks. And they found that the mean equity improvement with the combination is 2.7 letters, and ranibizumab alone was 0.3 letters. So just a small, very marginal benefit for pure ranibizumab, which is not less than 0.05. Of course, dexamethasone and ranibizumab had a greater reduction in central macular thickness reduction, and they kind of put it out that adding dexamethasone to ranibizumab offers no significant advantage. Plus remember that this was for persistent DME. But then a small substance again showed that with pseudophakic eyes, the gain was just 3.1 letters, but a little more than in phakic eyes. So Helian and Wang looked at combining IVTA and Avastin and found that there was no significant advantage of doing so. And we also did try it in Arvind and really didn't find a tangible benefit. The Bevodex study looked at a head comparison between Ozurdex and bevacizumab, a prospective multicenter trial. The 88 patients, they found that bevacizumab did far better than dexamethasone implant in terms of equity, but in terms of central macular thickness, it was more or less the same at the end of 2 years. But what you do notice in this little graph is that there's a sudden rapid reduction. So if you want a quick reduction of diffuse macular edema with steroids, you do get that. You can see that how quickly it falls within the first 4 weeks itself. But I'd like to direct your attention to this subset of pseudophakic eyes, which is just 26, but still you see that the visual benefit is more or less the same. So there is a role for IVTA perhaps in pseudophakic eyes, especially if they are elderly, because the incidence of IOP, steroid induced IOP, reduces with age. So it's more in younger patients, less in elderly patients. So elderly pseudophakics, it's a role. So Ozurdex may also be used for refractory DME, as the MEAD study showed. And so this is Ozurdex. And one place where Ozurdex really stands head and shoulders above other anti-VEGF agents is in vitrectomized eyes, where there is residual diabetic macular edema. So the Ozurdex, the pharmacokinetic doesn't change a lot. It stays. All other drugs, anti-VEGFs, they'll get washed out within a week. So this is one place where there is a role. So I'd put that out as the USP right now. Fluocinolone, the FAME study with registered, that came through, and 0.2 versus 0.5 milligrams were looked. Gain in letters are more or less the same, more than a quarter at 15 years, but unfortunately cataract and glaucoma surgery was pretty high with the 0.5, and this study kind of put it in disrepute. Of late, Iluvien has come out in the Western world, which is again, like Reddy said, a sustained drug delivery system. It's a drug matrix with 3.5 into 0.37 millimeters non-biodegradable cylindrical tube, as you can see there, through a 25 gauge intravitreal injection process. The zero order kinetics are slow. It lasts 2 to 3 years in trials, but generally about a year and a half is what we hear from our Western colleagues. And this is a great thing. This, unfortunately, this is not there in India. And if it does, we expect it to be a lack or something. But then it is pretty useful in refractory edema, and so we hear from our colleagues. So Campuchiero showed that there was significant equity improvement with the 0.5 microgram dose, and the IOP increase surprisingly was not as much as was expected when they began. Now, this was an interesting study around El Hamid from Egypt looked at combining Ozurdex and micropulse laser, and they did it in 20 anti-VEGF non-responders. So this is a pretty good idea. And they used 5% duty cycle, 400 milliwatts, 200 milliseconds, 1 year's follow-up, and they found that 75% had improvement, 25% was stable, and only mild ocular hypertension is there. 40% needed about an injection. I'll just finish in a little while. So the European DME recommendations for steroids as first-line therapy is history of a major cardiovascular event where anti-VEGF is unsafe, although those not willing to come for monthly injections, pseudophakic patients, and a second-line therapy where there's insufficient response to anti-VEGF, non-steroidal responders with chronic macular edema, and those who can't get access to approved agents. With RVO, the Geneva showed that Ozurdex was useful. I'll quickly cut to the chase. Comrades compared anti-VEGF with dexamethasone, and the extension study showed that dexamethasone had a peak effect at about 8 months. And there was, of course, the issue of IOP rise. Number of injections was, of course, much lesser. And in the uveitis, we know that steroids definitely play a role. This is an example of a uveitic CNVM where we combined anti-VEGF with steroids and found benefit. As you can see the regression there. And in case of posterior scleritis, you can see this conical PEDs of posterior scleritis, and we just melted off with steroids. A few other miscellaneous in Coats disease, chorangial hemangioma, spelling, with exudative detachment and ocular hypotony. So in summary, anti-VEGF steroids are indicated perhaps when anti-VEGF is relatively contraindicated. Recent strokes, acute myocardial infarctions, uncontrolled hypertension, diffuse DME combination therapy may be considered. Deferred laser, especially in non-center DME, there's still a role for laser. Elderly pseudophakics, as I mentioned, and perhaps Ozurdex, if possible, is a better option for the patient. Refractory macular edema, refractory pseudophakic macular edema specifically, a combination of dexamethasone and anti-VEGF PRN has been shown to have faster sustained resolution of macular edema. Ozurdex and subthreshold micropulse, as I mentioned. Iluvien, if possible, in chronic refractory edema. In vitrectomized DME would be a great role or use. The uveitis, as I mentioned, and in cases of hypotony. So Jose Jonas has shown us that he's taken the supernatant off and concentrated and given up to 25 milligrams of steroid as a concentrate and maintained pressures for a long period of time. But of course, as I mentioned earlier, you have to be careful about steroid-induced IOP rise and cataractogenesis. Thank you.
Sir, thank you for the wonderful talk. Just one question, sir. On looking at the OCT, what OCT marker will in diffuse DME or anything will force you to give Ozurdex?
So nothing forces me, but let me say that if you have a large amount, relatively disproportionate amount of subretinal fluid, and you need the patient to get equity quickly, as I showed you in that graph, then perhaps you might think of steroids, and depending on if the patient can afford, you probably would think of Ozurdex more. And Ozurdex has been shown to have a lesser incidence of IOP rise than triamcinolone. So different people, different studies have disagreed, but especially in Western population. So in these situations, perhaps yes. Also another situation which is again debatable is the presence of hard exudates. There's a lot of hard exudates. Some people have said, in fact, there was a study published in Retina more than 15 years ago, which showed intravitreal steroids as being beneficial for resorption of hard exudates. We tried it around the same time to time. We didn't find that much of a benefit, so I can't stand very strongly there. But I mean, of the two, I would say, since you asked me the question, I would say disproportionate amount of subretinal fluid. Perhaps that's a good indication. Yeah.
Okay. Sir. Any last thing? Hyperreflective dots, sir. Any?
Yeah, I didn't want to get into that because 6 minutes. That was a complicated study.
Okay.
There is a study by I think somebody by Korean authors which showed clearly that in diabetic macular edema, if you have a lot of hyperreflective dots, those patients in their study, 75% of them were non-responders to anti-VEGF, and surprisingly, those that had dots, 70% of those non-responders were responsive to steroids. And the rationale, the thinking is that those hyperreflective dots represent Muller cell fragments. So therefore, it is an inflammatory issue, and therefore perhaps the role of steroids.
Thank you, sir.